Hello, everyone. Can everybody hear me okay? Okay. I feel like it's right before lunch, so everybody's either so hungry that they're going to stay awake for this, or they're so tired of sitting home fidgety. So I'm really pleased to be here today to talk to everybody about primary care, behavioral health integrated services. And I just want to say before I start that, you know, as Vanessa said, I've been in the field for 21 years, and prior to working at El Rio, I had no idea that this existed. And I also didn't know about the connection between medical illnesses and mental health, even though I'm a licensed therapist, you know, but just no idea. And so this is, to me, a really powerful model and a way that we can really help patients who may never make it over to a behavioral health, a traditional behavioral health setting. And so I'm really happy to share this with you today. Okay, so today we're gonna talk about what behavioral health integration looks like in a medical centered home, which is, or I'm sorry, a patient-centered medical home, which is what El Rio here is. We're going to look at two different models of integrated care, and by the time you guys leave here today, you'll have some ideas of interventions that you can use for integrated care, as well as some of the things that an organization needs in order to put this model in place. Okay, so these are just some questions that I put together. You know, for some of us in here, this is brand new information, never heard of this before. And so if you work for a health center where you think this might be something that could be started in your center, these are some questions to think about as far as whether or not this would be possible. And if not, these are goals to work towards for your health center in order to make this something that you can do for your clients and your patients. And so I'm not going to read through all of these, but just as I go through my presentation, just kind of think about these questions, and we'll go back to them at the end, just to see if you know, this is something that you might be able to do where you work. Okay, so what is integrated behavioral health? So it's really, it's a collaborative approach that takes place out of the primary care clinic. And so it identifies behavioral health and physical needs and treats both of them while the patient is in the primary care clinic. And so, you know, a lot of people who work in primary care know that a lot of the reasons that youth go to primary care visits, youth and adults, is because of behavior problems and psychosocial distress. That fuels a lot of the medical problems that people have. And so this is an example of the two different models that I'm going to talk about. So in the first example, you have an adolescent who has type 1 diabetes and has depression. And so the behavioral health needs in this case are related to the medical condition. So if you have an adolescent who's living with type 1 diabetes, that's really difficult. There's a lot of lifestyle changes that they need to do that are not similar to a normal adolescent's life. And so that can bring about depression. The other example, you have a school-age child with anxiety. Some of the symptoms of anxiety are headaches, a GI upset stomach. And so in this case, the physical symptoms are related to the behavioral health condition. And so the two models we're going to look at address both of these in different ways. And so these are the two models. So we're going to look at primary care integration, and we're going to look at a model called collaborative care, which Dr. Arredondo mentioned in her presentation. And so, you know, why do we need this? So this is the ACEs model. I don't know if everybody here is familiar with the Adverse Childhood Experience questionnaire, but this is the model that it uses. And if you look, the second, is there I was looking for the pointer, I don't know if it's on here. But the second to the top says disease, disability, and social problems. So that's what we see. That's what comes into the primary care clinic. But what fuels it, if you look at the very bottom, it all starts with adverse childhood experiences. And so these are some of the categories of adverse childhood experiences. substance abuse, parental separation, divorce, mental illness, domestic violence, criminal behavior, different types of abuse and neglect. And so what the ACEs research shows is the more of these that somebody has, the higher their risk for physical health and mental health problems. And so when we apply this to youth, you can see that these are all health conditions that youth have: asthma, somatic symptoms, headaches, obesity, dental health, sleep disturbances. So the X number of ACEs, so if somebody has 4 ACEs, then they're higher risk for developing asthma. Okay, if they have 5 ACEs, sleep disturbances, 3 ACEs, an increased incidence of chronic disease. And so the research has shown that this is definitely linked. And so the first model we're going to look at is primary care behavioral health, and looking at how behavioral health clinicians can help with some of these medical symptoms that youth are living with. So primary care behavioral health really looks at improving clinical outcomes. And so the first one is enhancing short-term outcomes. So what that looks like is, what is the plan for today? So as they leave the PCP's office, what are you going to do as you walk out of here to help improve your medical condition? And then in doing that, it enhances the long-term outcomes. So if they have a plan for things that they can do differently, then over the long term, their general health condition is going to improve. And then of course that helps to control medical utilization and costs. So they're not going to the doctor as much, they may not go to the hospital, the urgent care, and then the medical care costs go down. And so this table is a good example of the difference between primary care behavioral health and specialty behavioral health. And so specialty behavioral health is kind of what we think of traditional behavioral health. It's the psychiatrist, it's the case manager, it's the counselor, it's the peer support person. And so the patient is the main customer, if you want to call them that. And the goal is to resolve their mental health issue. They go to a specialized clinic, they get psychotherapy, and they work with the therapist, the case manager. So in primary care behavioral health, these are all independently licensed clinicians, LCSWs, LPCs, psychologists. And in that model, the primary customer is the doctor, the primary care doctor. So they're really working collaboratively with the physician to help the patient. And what a behavioral health consultant does, that's the name of the position, is that they support health behavior change in the patients that they work with. And so they use a consultative model, which means they go in for 16 to 30 minutes, and that's their session, that's their appointment. And the focus is on medical diagnoses. So everybody in here works in behavioral health, so we all know that medical goes along with mental health. And so oftentimes they go in for a medical, and then they find out that there's all these other mental health things going on, and so they can help address that too. And so what the team looks like is I have a dentist, a PCP, an OBGYN. You can have any medical provider as part of the team. And then the behavioral health consultant is the one that does the clinical behavioral work. And so at El Rio, we have behavioral health consultants that work with all 3 of these specialties. So we're going to talk about some key principles, and I'm going to use a case example to do that. And so we're going to talk about Marco. It's not an actual person. So Marco's 12 years old, and he comes into the clinic for his annual well-child visit. His mom is concerned because he's gained some weight over the last year. He doesn't really want to leave the house much. He prefers to play video games online. Prior to COVID, he was really active in sports. He did really well in school. His grades haven't really changed that much, but his teachers know now that he's less social. So the PCP will get the behavioral health consultant involved and ask that they go meet with Marcus and his mom, because he now has a diagnosis of obesity, which he did not have pre-pandemic. And this is happening everywhere. Kids I just actually talked to a pediatrician the other day, and he said the rates of obesity in children is so high now because of COVID. So the first principle is that the behavioral health services are delivered in an integrated model. And so the behavioral health consultant really supports the health interventions of the primary care provider. So they really look at the biopsychosocial factors that are part of the medical condition. And these types of interventions are considered a normal part of healthcare. So it's just part of the healthcare visit. It's just what happens. The patient comes in and sees the doctor, and then they see the behavioral health consultant. And so if we go back to Marco, the behavioral health consultant meets with him and does, a brief assessment to try to figure out what's really going on. And so what the BHC found out is that home isolation, Marco's on the computer a lot, his activity level's gone down, he's anxious, he has trouble sleeping. His mom tried to get him to socialize with friends over phone and Zoom, but he's just not really interested, and so he starts eating more snacks, drinking more soda. Mom works at night, she's out of the house, she's a single parent, he's alone, and so he's eating. And because he's eating and doing less exercise, his weight is going up. So the second principle is that the behavioral health consultant really targets treatment to patients with medical and behavioral health problems. And so oftentimes maladaptive health behaviors are a result of the 4 things on this slide. And so you'll find that children and adults who don't take good care of their health have a lot of skill deficits. They don't know how to do it. Their perception of their ability to do it is not accurate. They have a lot of distorted thinking about not only their ability to do things differently, but their actual health condition, and then erroneous beliefs. And so oftentimes what BHCs do is they will use tools from cognitive behavioral therapy, which addresses all of these, as well as brief solution focused therapy and motivational interviewing. So we're still using clinical skills, but we're focusing on the medical condition versus the mental health condition. So we go back to Marco. So what the BHC does is she uses motivational interviewing to help him define what he thinks good health should be. We all know working with kids, we can't tell them what we think they should do because they often don't do it. So we have to get it from them. And so they develop goals related to increasing activity. They create an action plan related to exercise. So that's a CBT tool. And then the BHC uses CBT relaxation skills to teach him how to manage his anxiety without having to turn to food in order to do that. And then, BHCs often make referrals, and so she suggests that they meet with a registered dietitian to help them plan healthy meals on a budget. Another principle is that the behavioral health consultants promotes interface between medicine, psychiatry, and specialty behavioral health. And so the BHC, because they're in the room with the patient, they can triage any mental health issues that might be going on. And so in Marco's case, they gave him the PHQ-9. He scored a 15, and on the question about whether he thinks about hurting himself, he said several days. And so the BHC then does a further assessment to see how serious is his suicide risk, and then discusses a referral to specialty behavioral health so he can get some counseling and possibly some medication. The fourth principle is that primary care team members are the primary customer, and so the primary care doctor remains in charge of the patient's care. So what that means is there's no treatment plan, there's no biopsychosocial assessment, there's no 90-day review of the treatment plan. BHCs don't have any of that stuff. And interventions are 16 to 30 minutes. And when the BHC finishes with the patient, they'll go out and talk to the doctor about what they found out and what they did. And so the BHC goes back to the doctor and tells the doctor what she found out about Marco and the recommendations, and then the primary care doctor puts the referral in for behavioral health and for the dietitian. So they work together. Oops. And then the fifth principle is that primary care behavioral health is grounded in a population-based care philosophy. So what that means is that services can be designed to meet the needs of the population where they are. And so in this, example, which I just said, primary care physicians have noticed an increase in obesity. And so the BHC is in a really great role to help with this. And so what they do is they look at the schedule for the day. Who are the patients that are coming in that day that have obesity? And they go and they particularly see those particular patients on purpose to help with that. They also work with the registered dietitian to develop materials available for all of you when they come in the clinic to help, prevent this problem from starting in kids where it hasn't started yet. And then here at El Rio, we're fortunate to have a department that is a wellness department, and they've actually developed a group for youth who are struggling with weight and weight-related illnesses, and the BHC can be helpful in doing those groups as well. So there's different types of visits that behavioral health consultant does. The main visits are the behavioral health assessment and the behavioral health intervention. There's also groups that BHC can do. Those aren't your traditional therapy groups. They're health-focused groups. So you might do a group, they might do a group on sleep and talk about, for sleep reading, and talk about different ways that you can get better sleep. They could do a group on obesity and talk about behavioral change related to obesity. So the initial consultation, when they go in, they gather information, they figure out what is the issue, they make recommendations, and then they close the visit and consult with the doctor. So these are one-time visits. There is the option for the behavioral health consultant to see the patient again if they want to schedule it, but oftentimes they just see the patient one time when they come in. And so I have a video. I think this can be kind of a hard thing to wrap your head around unless you actually see it in action. And so I've got a video. I don't know how to...
With Dr. Smith, and like I said, we'll have about 10 minutes.
Okay.
All right, so I'm going to ask you a bunch of questions just so that I can kind of figure out a pattern to these headaches.
Okay.
All right, so question number one, who are you living with right now?
I'm a roommate.
Okay, got a roommate. You guys live close to here?
We live down by the middle school.
Okay. Are you in medical school?
Mm-hmm. First year.
Oh, first year. Oh, wow. When did you guys start?
September.
September.
Yeah.
Okay, so it's been a couple of months.
Yeah, we're getting to that.
All right. And did you have to move here from?
I did.
Where'd you move from?
California.
Okay. Wow. Have you ever been up in the Yakima area before?
No.
Oh, so
I came up to visit my interview and stuff, but.
Okay, so just the interview, that's your only?
Yeah.
Okay, and you've been here since the start of the year? And
yeah, it's moved up like mid-August and then started at the beginning of September, this semester started.
Okay. And your roommate is another medical student?
Yeah.
First year?
First year.
All right, so y'all are in the same, little bit in the same boat?
Yeah.
Okay. A few other questions about the situation. Are you in a relationship or dating anybody right now?
Not right now.
Not right now.
I had a girlfriend in California who broke up.
How long ago break up? How long ago did you guys break up?
It was probably shortly after I moved here, so maybe like right at the beginning of September.
Okay. Was it a pretty serious relationship or?
We've been dating for a few years. Yeah.
2 years.
Yeah.
Okay. But do you feel like, it's for the better or still kind of hurting on it a little bit?
At the beginning I was a little upset at the beginning, but it was a mutual breakup. It was just the distance wasn't gonna work.
Okay. So in the long run, this might be a better.
Yeah.
All right. And not dating, like you said, not dating anybody now.
I do not have time.
Okay, super busy, which I'm sure we're going to get to in a second. So just real quick, with regards to your family, is there anybody in your family who you're particularly close with or spend time with and talk with?
I'm close with my parents and my brother.
Okay, they're in Cali?
Yeah, so my brother, he's actually in Utah. He's actually finishing residency right now.
Oh, wow.
Yeah.
And it's just the two of you guys?
Yeah.
All right, so your parents are in California and your brother's finishing residency in Utah. Okay, and then it sounds like they're pretty supportive, the three of them?
Oh, sure.
Okay, they're very supportive, all right. And as far as friends go, do you have some friends from home or maybe some new friends here that you spend time with?
Yeah, I mean, it's nice, they try to do a lot of, socializing of like cohorts at the beginning, so I was able to meet some friends and, yeah.
Okay. And then do you talk to anybody from back home still?
Every now and then, it's tough, I'm just really, really busy. Yeah.
Not even social media?
I try to stay away from it, a lot, just because.
I can see that.
Yeah, it's a little time waste.
Okay, and then, any specific like spiritual or religious or philosophical outlooks on life that are important to you?
My parents are Christian, I don't know, I still believe in God, but, I don't necessarily like, practice or.
Okay, so it's not like you go to church or anything,
No.
but you have a belief in God?
Yeah.
All right, and then now getting to the school, because it seems like that's, a lot of stuff is going around that. So being in medical school your first year, you're not even having much time, for much of anything right now.
No, it's just really stressful, I knew it was gonna be stressful, I'm just surprised that it's been as stressful.
Okay, and did you go straight from, straight into medical school, or were you working beforehand?
I worked in a research lab,
Oh.
in California, and, applied.
Okay, so you did undergrad and then,
A couple years as a research lab.
okay, then medical school.
Yeah.
Okay, and how many hours a week are you putting into this, to your classes, studying?
I have no idea. Yeah,
A lot?
yeah. Well,
Fair to say?
Yeah.
All right, has this left you any time for fun, hobbies, things you're passionate about?
I mean, I like sports, and my room and I mean, we'll try to watch football, like, the school has a fantasy football, league, so we
Okay.
do that, but, so we might watch football, I try to work out when I can, but it's really difficult to do.
Okay. And then, as far as the working out goes, are you able to do that a couple times a week, or what are we looking at for?
You know, at the beginning of the semester, I was doing really good, I was doing 4 or 5 times a week. Now, if I get there once or twice, I'm lucky.
Okay, so you're down to 1 to 2, and you were at 3 to 4.
Yeah.
Okay, and then as far as your sleep goes, you said that you're putting in all of these hours. Do you have a routine to your day?
You know, since these headaches have started, my sleep has just been bad.
Okay.
I don't know, maybe my sleep was a little bad before the headaches, and I don't know which came first, but whatever, the both really feeding off each other, and sleep is it's terrible right now.
Do you have like a set time that you go to bed, set time you wake up?
I mean, yeah, I love to go to bed like 5 midnight, but usually I'm going to bed like at 2.
Oh my,
Yeah.
you studying or?
Both, you know, I can't fall asleep, so I just end up studying or just go back to reading and not supposed to be asleep, but I just don't.
Okay, so normally you're going to bed at closer to 2?
Yeah.
And then what time are you waking up?
Well, in an ideal world, I wake up like 6 or 7,
Okay.
but lately, I'm not falling asleep until later, it's like usually like 8, and I wake up, which then we're going to interfere a little bit with my classes, and I have like this labs I'm supposed to do, which is,
Okay, so in a perfect world, you go to bed at 11 and get up at 6 or 7, but right now you're up.
Yeah.
Your schedule's kind of thrown off.
I'm just really worried I'm not gonna be able to do it. I'm really worried that like it's gonna mess up. Like this is really like I can't have bad grades. Like I can't mess this up.
Yeah. So you're definitely. It sounds like you're worried about being able to get the kind of grades that you need to be able to go to your labs and do everything that you need to do. How are your grades right now?
I mean, they're okay, but I mean, everybody told me like this is like the semester that's not supposed to be hard. The next semester is supposed to be like really hard.
I see.
Which is freaking me out right now.
So if this is hard now, you're thinking this is hard to get through. If next semester is even harder, that's kind of really making your mind go.
If these headaches continue, I don't know what I'm gonna do.
Okay, I definitely want to get a little bit more to the headaches. Is it okay if I ask a few other questions?
Yeah.
As far as your eating, how many meals a day are you getting?
Yeah, that's horrible.
Like low?
Yeah.
Okay.
Yeah, I didn't eat that much.
Are you getting meals in at all, or snacks, or?
Maybe some snacks. I usually do try to eat lunch with my roommate in classes, but then maybe dinner. Yeah.
Okay, so about 2 meals a day, and then are you able to snack in between, or?
Yeah, but that's gone down.
It's gone down. Are you drinking water during the day?
I'm drinking a lot of coffee and energy drinks.
Okay, how many coffees a day you drink?
Lately, I'm tired. I'd probably say 3 or 4 cups.
3 or 4 cups, and as far as energy drinks, how many a day?
Maybe, I don't know.
2,
Yeah.
3,
6,
5?
2.
2 to 3. Sure.
Yeah.
2 to 3 a day, and are they, which ones are they, like Monster, Red Bulls? Or?
So I used to drink. I'm drinking like bananas now.
Okay, and they're like those 12-ounce cans. The bigger ones, so like 16-ounce ones?
No, there's a.
Oh, 12 ounce. 12 ounce. So 2 to 3 12-ounce ones along with 3 to 4 cups of coffee a day. Okay, cigarettes, alcohol, how much?
I guess that is something I do usually on weekends. So I'll drink a little bit of it.
We're talking, 5, 6 drinks or 2 drinks?
2 to 3.
2 to 3. Okay. So somewhere in
It's
the middle.
usually one of the brews.
Oh, one of the breweries, and how many times a week you said? Oh,
It
weekends?
might be, it should be once a weekend, but it could be like Friday, Saturday. It's usually just once.
Okay, and is that causing any problems? I mean, marijuana?
No.
Not
No,
interested?
no drugs.
No drugs, not taking anything that's illicit?
No.
Okay, gotcha. All right, so, it sounds like, if I'm picking up everything correctly, it's the stress with regards to school, as well as the headaches that are now causing stress. Headaches, are they happening like all day? Like when did these, maybe I should just start with one question. When did these headaches start?
Mid to late September.
Okay, and then how often are you having them?
Every day.
And then throughout the day, how much of the day?
With me all night.
All day?
I mean, there might be a little bit of breaks, but usually when I don't have a bad night of sleep, I wake up with a headache. Sometimes the coffee makes it better when I have a drink, and but it's usually mostly throughout the day.
Okay, so these started once you're about a month into school. They happen all day, every day, and then they get worse when you didn't sleep well, but they might get a little bit better when you're able to get some caffeine in you.
Yeah.
Okay, and right now, as far as these headaches go, what do they stop you from, or do they stop you from doing anything that you need to do?
Not school yet. It makes it hard. It makes it really hard. And then I have a difficulty with like I don't want to like socialize and stuff. Like that,
Yeah,
but,
because you're.
yeah, but no, not really. I'm good.
Is there anything that you found that's made it better?
No, I mean I try to, be in dark rooms. That doesn't necessarily help at all. Getting good sleep sometimes does.
Okay.
Like on weekends, I'm not as bad.
Okay. Nothing else that you've noticed that helps take them away? And did you have these headaches before you got to med school like this?
No, first time.
No, this is your first time
Yeah,
experiencing.
I always think that.
Okay, so we're gonna just stop it for the sake of time. So this is a good example of what a visit with a behavioral health consultant looks like. And so, he probably came in because he's having headaches, thinking he's gonna get some medication from the doctor, and he might. But, I mean, there are all kinds of red flags as to why this guy gets headaches, right? So, he's probably not gonna drop out of medical school, which might be the solution for him. But the BHC can help him create a plan for better, how is he gonna get better sleep? How is he gonna manage his stress better? How is he gonna have some time in his day to do enjoyable activities? How is he gonna eat better? How is he gonna drink less coffee? So there's all kinds of things that the behavioral health consultant can help this guy with to help him reduce his headaches, other than giving him medication for it. Okay, and so everybody should be able to get there's a handout that shows different medical issues and what are some good interventions that PHCs can do to help patients with that. And so the next thing I'm going to talk about is collaborative care. And collaborative care is the bridge between mental health diagnoses and primary care. Whereas primary care behavioral health is about medical diagnoses, this is about mental health diagnoses. And these statistics, I think, are really interesting. So only 20% of patients receive behavioral health care in a specialty setting, 80% receive them in primary care. And 50% of people referred to a specialty behavioral health clinic from primary care don't follow through. So a lot of the patients that get seen in primary care for mental health will never be seen by a specialty behavioral health provider. The other statistic that I think is really interesting is this model. In 2016, there was a study done looking at patients from 2008 to 2013. They looked at 7,000 patients, and they found that primary care clinics that use this model, their patients had remission in symptoms in 86 days versus 614 days if they had usual care. And what usual care means is medication and a referral to specialty. Okay. The other thing that I think is really important to note is that when we talk about suicide, a quarter of the people who committed suicide received mental health care in the last month of their life, but 50% of these people saw a primary care provider. So we can really help intervene on severe depression in the primary care setting with this model. So the team is a little different for collaborative care. It's the primary care provider, somebody called the behavioral health care manager in this model, and the psychiatric consultant. And so what it really looks like is the patient comes in to see the PCP for depression, and the PCP may do the PHQ-9 and they score really high on it. So the PCP thinks, collaborative care, this would be great. So they talk to the patient about it. Patient agrees. The patient has to sign a consent form in order for them to be able to be involved in this program. And then the PCP does a warm handoff to the behavioral health care manager. What that person then does is engages the patient, and throughout their care, they do care management, and they also do brief psychotherapy with the patient. And then what the psychiatric consultant does is they make recommendations. So the psychiatric consultant never actually sees the patient unless the patient is in crisis. They consult only with the PCP about questions the PCP may have about medications. And so there's 3 levels of care. There's care initiation, follow-up care, and maintenance. Another piece that's really important to this model is having a registry. And so what the registry does is it's basically a table that has different things that it tracks. And so it tracks how often patients are seen. It tracks what their PHQ-9s and their GAD-7 scores are over time. It tracks trends of patient symptoms, and it tracks length of time of treatment, frequency of visits, when was the last time this patient was discussed with the psychiatric consultant. And it also tracks minutes of service. This model is billed on minutes of service, and so the registry tracks that as well. So another case example, so this is Maria, she's 15. She goes to her PCP with her mom, and she's not sleeping well, headaches, feeling run down, tired during the day. She worries about her grandmother getting sick. So the PCP gives her the GAD-7, and Maria scores a 14, which is moderate anxiety. So the PCP reviews the GAD-7, introduces the program. Patient and Maria and mom say, let's do it, sounds good. They do the warm handoff. The behavioral health care manager meets with them and schedules a time to do a full intake in the future. They meet again, they do the full intake. The behavioral health care manager administers the PHQ-9, so she can also watch depression symptoms. Provisional diagnosis of generalized anxiety is made. There's some education about this is what that means, and this is what the symptoms for this mean. The behavioral health care manager meets with the psychiatric consultant and discusses the symptoms. And then the PCP thinks, well, maybe we'll try Cymbalta. And so they need some help on how to administer the medication, what the titration schedule should be like. And so they will consult with the psychiatric consultant about that. And then the psychiatric consultant gives the recommendation. The PCP follows the recommendation. So this patient doesn't even see the psychiatrist. It's not necessary. And so then so that's care initiation. So then in the second level of care, the behavioral health care manager meets with Maria several times, does some CBT with her, to help her improve her goal of getting better sleep and decreasing worry. They meet every 2 weeks. This can happen over the phone, this can be telehealth, this can be in person, whatever works best for Maria and the care manager. The PCP then will see Maria for a follow-up visit, ask her how she's doing, how's it going with the Cymbalta, do they need to make any adjustments to the dose? And then over time, this is basically what services look like. So behavioral health care manager is administering the GAD-7 and PHQ-9 at regular intervals to see how her symptoms are doing, engaging her in therapy. And services will continue until Maria has a decrease in her GAD-7 score of 50%, or until her score is under 9. And at this point, they move into the monitoring phase, which means they meet one to 2 times a month just to check in. And then termination occurs when her symptoms when she's stable enough to terminate. So that's kind of a really quick overview of collaborative care. But it's really a great model. There are some resources in here, and Dr. Arredondo mentioned the AIM Center, which is out of the University of Washington, and they really have a lot of material on their website about this. So I would encourage you, if you're interested in learning more about it, to go there. They have free office hours. So if you want to attend, they have an office hours that deals with the financial piece of it, and they have an office hours that deals with the programmatic piece of it. And you can just join, it's free, and they'll answer any questions that you have. They also have some really good webinars that you have to pay for, but those are available as well to learn more about what this model is and what each person does in the roles. So back to our key questions, as we've gone through all of this, and hopefully everybody in here is like, yay, I want to do this in my organization. Just some things to think about. So does the mission include integrated health services? Would the medical providers in the organization support this? That's key. The medical providers have to support it, and they have to be on board with it, and they have to understand it as well. Okay. Can the organization financially support the development of it? Payer mix is important, so certain insurances don't pay for this. Access does, and so do you have the right kind of insurances that you're contracted with to be able to financially support one of these programs? Do you have enough qualified staff in your area, and if not, do you have places you can get training on this? And will your electronic health record allow for integrated care? That's the other thing. With the registry, it has to be done electronically. It doesn't have to. You can do it on an Excel spreadsheet, but it's much better if you do it electronically. And some medical records systems will support that. And so I just put a bunch of resources in here for everybody, and then the references. That's it. Okay, so the first question, what are some ways of getting medical providers on board with letting the VHCs see the patient? Oh, that's such a good question. So that's one of the things at El Rio that we've worked really, really hard on, and I think it starts with training. I think when a medical provider gets hired on to the organization, meeting with them and explaining to them this is what primary care behavioral health is. This is how it's going to help you help your patient. That's the key, because we're really there to help the doctors help the patients. So if we can help them to understand that they are all in. The other thing is, if you have providers who are not new and they don't know about this, having a training, going around to the different clinics, meeting with the staff, meeting with the medical assistants, and explaining this is what we do and this is how we can help you to do your job more efficiently and to help your patients better. And I think those are the key things, to help. I mean, you can show them research all day, but I think just having a dialogue with them. I mean, we're all here because we want to help people, and as are the doctors. And so we're talking with them about it and showing them ways that we can help, I think, is the most effective. Oh, that's a good question. So I see many individuals go to a provider for medical issues and leave being told it's anxiety or it's stress, which can come off as dismissive or harmful. How does this method ensure patients don't leave feeling unheard? So that's a really good question. And I think the opposite happens with the behavioral health consultant, because when the primary care doctor goes in, they have 20 minutes maybe to see the patient because they have 25 to 30 patients to see that day. But the behavioral health consultant can spend 30 minutes with a patient. And so we go in and we listen. And we may go in for, this happened in the pandemic all the time. We may go in because somebody's there for diabetes, and then we find out that 3 of their family members died last week from COVID. And so you end up talking about death and grief and loss and how that affects their ability to take care of their diabetes. And so they actually feel more heard when they work with a behavioral health consultant than when, you know, the primary, not that the primary care doctor's doing a good job, back in the room, but they don't have time. They're busy. They've got all these patients they have to see, you know, and so, and I think validating, like we do a lot of validation. It makes sense that you feel this stress, you know, let me help teach you some ways to deal with this. And then teaching them how to do progressive muscle relaxation in the exam room while you're talking to them, so that they walk out not thinking it's just in their head, but, you know, of course you feel this way and here's a tool to help you. Can both models run concurrently? Yes, both models can run concurrently, and actually LRIO is in the process of starting the collaborative model, so we are going to run both models concurrently. You just need to staff them differently. Are there any issues with state licensing, having trouble with depression? How can we prevent that? When you, I don't know if the person who asked this is here. Okay, when you say state licensing, are you referring to the licensure of the provider or of the organization?
Organization, the medical facility licensing.
Boy, that's a good question. I don't know that answer. Does anybody know that answer? Do you know that answer? Go ahead.
She doesn't know that.
Oh, you don't know the answer. Okay. She doesn't know the answer.
I can talk to her about it later.
Okay. Okay. I'd love to know too. Okay. Can you touch base on BH? Okay, yeah, good question. So, so primary care behavioral health also has an arm to it that's called behavioral health triage. And so those are behavioral health consultants who primarily focus on crises in the medical clinic. So if they're in the clinic and the PCP is seeing a patient and the patient is psychotic, suicidal, extremely tearful, any sort of extreme emotional reaction, then the behavioral health triage consultant will go in and see the patient. And they basically work on developing coping skills in the moment and developing a plan to get them to the next level of service if they need that. Usually, so this may not be information you're looking for, but those visits are usually billed as crisis visits, so that because they're for mental health reasons, and so that's the role of the BH triage. Okay.
Yeah.
Thank you.
I got you, guys.
Minutes before our next presenter at 11:45. So if you want to take a break.